supposed to have this on, right? Yep. The point of this whole bill that's been going on now, my understanding since 2017, is that we know that there's a problem with pain care in the United States, that we have a prescription and a procedure epidemic, but we don't really provide access to services that we think help, meaning like integrative care, which is putting all these things together in a unified piece, which we know works for chronic disabilities. That model works the best. But we also know that we tell people you can't have pills, but we think you should be able to do this, this, and that. And the patient will commonly say, well, I can't access that for a variety of reasons, not the least of which is cost. So the whole point of this bill from the very beginning was to provide an alternative to opioid therapy that people have been asking for a long time. I think we've made some progress, but we have a long ways to go. And that was the point. So the next thing that we've been doing, this has been an ongoing discussion that some of us in this room have been involved with for at least 6 years. And it's actually what led to me running for this office, which is why I'm sitting here right now. And maybe we'll be sitting here again in January, hopefully. I did check with my mental health expert and they said it was fine. But anyways,
Anybody running against you?
yeah,
Oh,
a lot of
is
people,
that right?
4 Dems and 6 Republicans all together,
It can't be all, they must be. in the-
4 seats
Oh.
for 4 seats. Yeah. So, yeah, it's going to be a challenge.
And how many are Democrats? Because they're not gonna win.
There's 4 Dems in our running in our district, I think. Pretty much sure 4. And so they won't have a primary. They did that on purpose. I actually work with them on a regular basis on a lot of stuff, so I know the inside dirt. But the Republicans, there were 2 new ones that chose to run.
You'll win.
We'll see. I'm not as confident as you are. But anyway, so that's kind of where we are with this bill. I think the bill needs a lot of work. I tried to put together something that I've shared with all of you. And I would be happy to start anywhere. Representative Palmer and I talked in the cafeteria earlier, and I don't know how much you want me to go over the history of this before we get into that. All right. So, actually, I met Ms. Kroll and Ms. Dunlap like as part of this process about Gary Merchant, Representative Gary Merchant, several years ago, put together an ad hoc committee to look at how we provide non-opioid therapies in the state. And I don't think there was a clear direction where we wanted that to go, but I was actually kind of not totally invited to that. I was actually supposed to go to a different committee, but Jim Potter asked me to attend on behalf of the Med Society. So I went, and when I sat down, when I realized that not a single person in the room knew what the CDC guidelines to opioid prescribing was, I knew that there was a problem. So I immediately gave a discussion on that. And the next thing I know is Gary Merchant says, you shouldn't be out there, you should be up here. So the next thing I know, and you were there too, and I got asked to go sit up there, and Peter Schmidt came later and whatever. But anyways, it was a really great process. That committee led to 3 bills, one of which passed, which is one that I wrote with, ironically, Bill Murphy, no relation. But it changed the way we allow prescribing opioids in the state, which helped patients, which is a good thing. But anyways, in the midst of all that, Representative Mangiaputi was there at several meetings, and she was talking about a bill that she wanted to create. That basically is what the first 2 sections of this bill are, or 3 sections, I think. The ones that are all blued out. So, it was the problem with the bill was it made sense. It wanted to increase access to these services, but it put in a lot of restrictions on doctors who prescribe. And so that raised a lot of warning signs for us because, to be honest, everything that was in that section was already in our rules. So We met together as a separate ad hoc group, Seddon Savage, me, Jim Potter, Mike Padmore, and Cindy Steinberg. And the reason why Cindy is important is she is a legislative director for the U.S. Pain Foundation and the executive vice president for the Massachusetts Pain Initiative. She's been involved in national pain policy for over 20 years. And there was a similar bill crafted in Massachusetts that she was the author of. So she and I have been friends for a long time, and I asked her to come up and get involved and advise us. So a lot of what you're seeing in the second section, the part that's not blued out in this, is the work that we all did together. We all agreed something needed to change.
But what's
How-
the purpose of that? Is that existing law?
Not really.
I wonder why. I've never seen that before.
Seen.
A different color.
Oh, that's me.
That's you.
That's
Okay.
me. So anything that's blue is an edit from the original bill.
Okay,
Yeah.
yeah, because I've never seen that before.
Oh, yeah. Normally it's red,
Yeah, right.
but my printer wouldn't do red for some reason. When it came emailed, you got it in red. My printer did it in blue. I have no idea why.
My printer won't do anything.
Yeah. So, so basically anything in blue that's struck out is something that's been taken out of the bill that was in the original bill. Anything that's in blue that's not struck out is an addition. So anyways, so that's kind of how we came down to this. You know, the way they did it in Massachusetts was, I mean, there was a lot of discussion between insurers, between providers, and they came to some conclusions that basically mandated insurers had to provide a plan on how they provide integrative services for pain care, that they had to provide so many visits for, I think it was like one particular modality that they could choose. And they gave basically the same things that are in this bill, the same options, you know, whether it was movement therapies, manual therapies. What's important to realize is we're not talking about physical therapy. We're not talking about occupational therapy. We're not talking about anything that's already covered well. So anything that's not covered well, that's provided, and this was the other thing that became very important in our discussions, because the original bill includes Tai Chi, yoga, Qigong, things like that. The reason why those were struck is those are not provided by licensed providers. So we came to the conclusion, based on a discussion with insurers as well, that the only thing that made any sense from a legislative point of view was that it had to be provided by a licensed provider of some sort.
Does it have to be evidence-based?
Yes, and to be honest, those words we can put back in here. I struggle with those words, but they actually were in here and taken out. I struggle with those words because right now, if you look at the Agency for Healthcare Research Quality's report on back pain, there's virtually nothing that supports anything for back pain. So that's when evidence gets kind of sketchy, with the exception of two things: lumbar epidural corticosteroid injection for short-term relief for radicular pain, and back surgery for radicular back pain. Those are the only things that have any evidence that met their level. With that said, there's an acupuncture project that lists 117 different diagnoses for which there's some element of evidence. There's plenty of evidence for cognitive behavioral therapy for treatment of pain. There is evidence for massage. There is definitely one of the things that was presented to our integrative pain care committee from Amy Goldstein from the Alliance to Advance Comprehensive Integrative Pain Management was that there's actually strong evidence that chiropractic is cost effective for acute back pain. There's the most cost effective intervention for acute back pain. So yes, that we probably should throw evidence base back in there in somewhere. But to me, I think we kind of need to define it, because I think we use that term a lot without ever defining it.
So, how does anyone want to recognize people to speak, or are we just going to speak?
Yeah, I'm pretty much done, I think, with the history. So, yeah, let's just have people talk. And we have 3 guests in the audience that are welcome to speak if they wish.
So is the primary goal of the bill, whatever the bill is, to have, as you put down here, access to evidence supported alternative therapy by licensed providers? Is that the underlying goal?
Yeah. And with that said, we do need to define what alternative therapies means if we're gonna put that word in there.
And what, so is this driven by insurance carriers? Is it driven by reimbursement?
Okay. It's driven by a lot of separate stakeholders. So I've met, as part of what I do, I meet with people all over the country in different disciplines. So I've met with massage people, chiropractors. I met with actually both of the state chiropractic agencies. I actually work with the Acupuncture Association. So we've met with all of them. They're the ones that are driving this. When I gave you the history, what I was trying to do was give people's position on this as best as I could, because it's not that simple.
No, the hard thing for me is.
So I'm glad you said that.
Right? Okay, so one of my concerns in practice was always figuring out who had pain. And so the definition of pain became an issue for me personally, but also for, so for those that don't know, I'm a police officer. And we deal with a lot of pain. And the way it presented was obviously very different for different people with different diets. So,
Can I help you with that?
please do.
So we have House Bill 66, now 1712, created a committee that looked at pilot programs. And I do want to stress that I think what we're doing here is different than that. And I'd be happy to address that if anybody wants me to. But our first session, we've spent the entire session coming up with a definition of pain. The definition that's actually in this here, if you look down at the lower sections, pain is defined there, but it's using the International Association for the Study of Pain definition. The only minor problem with that, and I think we should modify that to use the same definition that we used in the Integrative Pain Care Committee. But the definition actually appears twice in the bill. I can find it for you. But I really do think we should use the definition that we came up with, that Representative McKay was a huge help in helping us with, because he said exactly what you just said.
So that's the definition. Well,
And it's the definition, if you look at our report that I actually do have here. If you look at our report, we defined it there. It's not actually in the bill. And so at this point, it does not appear in statute. So we can do that.
Because what you added in the bill on page 4, and I think it's the bill of 20, is the pain needs.
Yeah,
Correct.
yeah.
And so you have in there a definition of pain, pain management, so plans, pain services, pain patients. So there is some definition of pain there.
Yep.
These are consistent with the
Yeah, those definitions actually came from Cindy Steinberg. So that's what they used in Massachusetts. And that's what they use nationally. But I based on our discussions, this went on for 2 hours. We can't, I'm sorry, I have this is the actual report. I'll send you a copy of the actual definition that we used. But it's the International Association for the Study of Pain met again. Within the last couple of years, redefined pain, it's broader, it's more biopsychosocial, but it was really more germane to what we wanted to do with that committee, and what this bill and that committee does overlaps a lot in that regard. So would that help?
So our goal today is what?
So
And then what are our options available? Because I think at the beginning, we can either kill the bill entirely and start all over again.
Yep.
We can agree to the bill that you put forward, that doesn't have a bill number yet. There's some alternative in between.
So this is what I'd like to do. I wanted to start a discussion. We don't even need to go over in detail what I did here if you don't want. which is fine, and we can look at it. What I would like to do is put together, if that's all right with you guys, because this worked really well for our prior authorization process and also a couple other things we've done, is put together a small group of people that represent multiple stakeholders, not just one, and sit down, look at this, and come up with something that, 'cause I'll be honest, I really do think we need to move with this. I don't want to kill this. But I want to do something that I think will be satisfactory from a lot of different perspectives. And what I wrote here to me is a starting point. And I was under the impression that we needed to have this done in the next week. I found out we don't. So we have the whole summer to work on it. But I mean, if that's okay with people here, that's what I would like to do. And then have everybody sit down, look at it, see what they think. I will tell you that the stakeholders that I've referred to, there's not a unanimous belief on this bill at all. Like I'm on the legislative committee for the American Academy of Medical Acupuncture, and I asked him, I says, why the hell would you want to do this? And I said, right now it's all cash. And a lot of the old school chiropractic is cash. Massage is cash, which means you don't have an electronic record. You don't need one. You certainly don't have to have an expensive one that ties in with other systems. You don't have to get prior authorizations. You don't have any of those headaches, and you can charge a reasonable price and do what you like to do without any stress. And about half of them will say that's what I want. And the other half says they want insurance coverage because it gives them access to populations they don't have access to now, meaning lower income people, things like that. The other little minor detail or problem that you guys have pointed out multiple times, what we're doing here only affects 22% of the insurance market. And that's a problem. And, especially when you're looking at lower income people, that group of people, you're looking really more at Medicaid, Medicare, especially people with disabilities, they're going to have potentially both insurances or maybe more likely Medicare than Medicaid. But we don't have any effect on that. This bill does not address the self-insured market either. That's like 78% of the market, and that's a problem. And I totally understand why the insurers have a problem with that, is because, you're basically limiting it to one small group, and that's why they have an issue. I'm speaking for you guys, sorry, but you feel free to say something if you wish.
Guys, who do you represent?
My name's Representative Tom DeLon. I'm a police officer,
Okay,
and I'm here primarily representing practice on
I'm Sabrina Dunlap. I'm Director of Government Relations for Anthem. Not paid role, I represent the American Health Insurance Plan Trade Association.
Oh, all right. You can hear me all right, right?
Yeah.
Okay. I had no idea we're online. Oh God, I should have left my suit coat on. Go ahead.
My interest is in mental health, and as you probably all know, mental illnesses are misunderstood and often antagonism towards those individuals. I'm retired now, but there's a neighbor of mine who comes over to see me, and he's very concerned about the people that live with him that are poisoning his food, and he finds that very disturbing. So he takes all of the food, puts it in his car, and now everybody is thinking this man is very strange, and instead of the fact that he's severely mentally ill. All I can do is to say, when you're upset, come and talk to me and see if we can't work this out. He's been a homeless person. He has addictions. He's got medical marijuana, which have got him into trouble at work because he has the medical marijuana in a package in his pocket. And the people at work want to know what's in his pocket. And I said, that's none of their business, kind of thing, so that people don't think so much about the issue of pain and mental illness, but it's been my experience. I was just telling my friend here that I had a patient that came to me. She was very angry with me as to how incompetent I was, and she was screaming and hollering. And she said, your competence is about as important as, she rattled off a number. And I said, can you think about that number? Turned out to be her grandfather's birthday. And it turned out that she was sexually molested as a child by that grandfather. She had carried that hate probably for 50 years. And that's what I was experiencing, was that hate based on that experience. It was very enlightening for me to hear what she had to say, because it was clear that what she was carrying was unresolved hate towards that grandfather that could never be experienced. So it was a unique experience for me to recognize that the importance of that, the hate part of mental illness. So I think what Dave is doing is very important, if somewhat unique in his approach.
I'd love to tell you it's mine, but there's a lot of people involved in this discussion.
Yeah, I meant your unique approach
Oh.
to legislation.
I wanted to let,
Yeah, go ahead.
is that all right, Bill?
Yep, no.
Yes, please. I feel so bad we're so far apart.
So good morning, Representative Nagel and members of the committee. So again, my name is Heidi Kroll. I work at Gallagher, Callahan and Gartrell, and I represent AHIP, which is America's Health Insurance Plan. So we're the trade association for the health insurance companies. So I appreciate Representative Nagel has reached out on a number of bills, a number of occasions. So we definitely appreciate the back and forth dialogue and the opportunity to work on this. There's a handout here, which I know I sent to Representative Nagel, and I'm happy to send it around to others. We prepared I think it was 2 years ago when we were, there's an ad hoc committee that was working on this issue. And so I just wanted to call your attention to it on the first page. So it's just a 1-page, 2-sided document, but on the first page, it does kind of go over the information. Again, it's slightly dated, but I think it, generally representative of where things stand today as well. Just to kind of about the different markets. And again, just a reminder that any legislation that is put into state law relative to insurance coverage mandates can only apply to the fully insured commercial market. So it's, as Representative Nagel correctly pointed out, it's not the self-funded, it's not Medicaid, it's not Medicare. And then within that fully insured market, there's the individual market, and then there's the employer-sponsored health plan market. So, and often the state does not apply mandates to the individual market because there could potentially be a state financial liability associated with that through the ACA. So it's just something important to keep in mind, because I think we need to remember that there are businesses, medium-sized businesses out there that are, continue to struggle to even afford to pay for health insurance coverage for their employees. And so we just want to always keep in mind about who's going to be paying the premiums. And it's, typically employers or perhaps employers and employees shared. So to keep that in mind. And the other side of this page, and I think it's probably, again, still representative. Perhaps there are some updates, but generally speaking, what the the carriers were covering in standard plans. And again, it's important to remember there's a whole variety of coverage benefits that carriers offer to try to have a variety of offerings and choices in the market for employers and individuals. And so there's a lot of variability, but looking at kind of some standard plans, you can see that chiropractic services, PT and OT, TENS units, all typically covered. Acupuncture coverage can vary, so there are some plans that may cover it, but not all necessarily. Gym reimbursement, again, the same situation, and massage can be covered if it's part of covered chiro, PT, or OT, but not as a standalone typically. And then meditation, again, not covered, but a number of the carriers provide resources on their website that's available not just to their members, but really to anybody. You can access it without a login or anything like that. And that provided a couple of links here that would get you to kind of meditation and mindfulness resources that the carriers do make available. So I just wanted to kind of make sure, it sounds like you all have that page, but I wanted to make sure that you had a chance to look at it. And just looking over my notes from when I testified on this. So, one of the things that we were concerned about, a couple of concerns, there were 18 services listed, and I haven't gone back to compare and see if there are still 18 services listed when it was qualified by the phrase including but not limited to, so which would indicate that there was an unknown number of other services, beyond those listed. And I think I saw the number 12 as, coverage of a minimum number of visits for each of the services. So that would be on every single plan. And so one of the concerns we had raised during the testimony when this bill had a public hearing is that could put upward pressure on the premiums. And I think that there was a fiscal note to the bill, although I didn't see it.
Yeah, I didn't see it
Yeah,
either.
so
I
I'm
looked-
not sure where that landed.
The thing I saw said that unknown
Okay,
is what I
okay.
saw.
So
Can I just address that one thing? Because that's important what you just said. So I did qualify it, and what I wrote here was that you could pick 12 as a starting point, 12 visits from each category, not from every service within that category.
okay.
I mean, that's a start. I agree with you. There's innumerable pain care interventions. I mean, you could go on forever, and we do need to put a limit.
Right.
Yeah.
Yeah, and I know, Representative, that you mentioned Massachusetts, the Massachusetts law, and so I don't have it right in front of me, but from notes I have here, in Massachusetts, the carriers are required to ensure that they cover at least 2 alternative medication treatment options. So it's the medication side, and at least 3 alternative non-medication treatment modalities. So my understanding is it's non-prescriptive. So, that, and of course there's, utilization management review and medical necessity that overlays on that or underpins it. So anyway, the Massachusetts law is certainly something we could look at if that's of interest to you.
It is.
And then the other thing I was going to mention, and I think it's come up in the House Bill 66 work, but it was something we raised in our testimony as well, is just also looking for the opportunities around starting with education for providers, both PCPs and other types of providers, about the alternatives to opioids. So less of a mandate, but more just focusing on some education and information aspects of this as well. So And then the final thing I'll say, which you've probably heard me say before, is that, covered services should always be evidence-based. They should be, based on clinical and scientific evidence. And so, we'd want to make sure that that's part of the conversation as well. And I know you said you wanted to work on this, in the coming weeks and months, and so we're happy to, continue to get information to you, but I just want to kind of give you a few touch points while we're kicking off the discussion today.
My only goal in that was ruining your summer. So, Representative Palmer and then
So,
Representative Murphy.
So, yeah, my question is sort of related to this, and maybe this is information maybe we need to get, which is, with concerns about the upper pressure on premiums, what's happened in Massachusetts with their bill? Has that been a problem, or are we substituting one modality for pain meds, and so overall it's actually not costing any more and maybe it's better for patients? And so that kind of information, for me, that would be very valuable. And I completely agree that the treatments we do include need to be evidence-based, because otherwise
I can answer that if you want. Do you mind? I can this be a discussion more than
Sure.
like a
Yeah,
yeah.
you're running the show, however you.
Did you want to? I'll
So I
say
just
what
want
I
to ask
need
you a question of the insurance people. From a provider perspective, forget about the premium cost, forget about the covered items, forget about the number of times that you can see a certain provider. If in general, what I'm trying to do is get at a very simple concept. Number one, we want to provide access for patients that really need the care. For whatever reason, whether they're mentally ill, whether they're poor, whether they're rich, whether they have insurance or not, we want to get access to care, right? Tell me if you agree with these principles. If the treatment is effective, meaning evidence-based, so we've proven that the whatever treatment we're talking about works, provided that the people given the modality, whatever it might be, are licensed within the state. And that's where it becomes a legislative issue. As far as I'm concerned, would the insurance companies cover that? Meaning that would they be supportive of any legislation that basically says, if it's an accepted provider license, if it is an accepted modality, if it is proven to be effective, and as far as I'm concerned, if somebody then wants to pay cash for whatever treatment they want, whether it's, eating herbs in the garden or whether it's, whatever it might be, that's fine with me. But once you step into the insurance realm, then you have issues regarding, licensure, accessibility, and whether or not it's effective or not. Is it your opinion that the insurance companies would support that sort of a concept?
So what I can say is I think those are two principles that we certainly would agree to. I
Well,
don't.
I put out a few. So what are the two that you mentioned?
Oh, you mentioned evidence-based and licensed.
Okay.
So I'm honing in on those two things. So I would agree with you that those are two principles that we would agree to. I don't know what necessarily our exhaustive list might be of
Right.
kind of criteria or whatever, but I would agree with you that those are two key.
Because meditation, you talked about meditation being effective.
or mind body, yeah, whatever.
Mind
yeah.
body. Okay.
Yeah.
So if it was proven, if the massage was proven to be effective, would it be covered by insurance?
So currently massage is
It's not.
covered if it's part of like OT, PT, Chiro, or some other piece, but
Let's say that they're not PT, OT licensed. They are massage licensed.
I
we're
don't
not-
believe it. From what I understood from the survey that we did 2 years ago of the carriers, that would not be covered. So,
See, from
me
my-
going
I
me
know
going
where-
down
I
to
know
Elements
where you're going. I
Massage,
appreciate it.
So
Sure.
for my very, very simple, orthopedists are very simple-minded. You've got pain, you want to have a procedure or you want to have a modality that's effective. You then want to have the people that are given it licensed. Then as far as I'm concerned, the insurance should cover it, okay? And if they don't, I don't understand why, okay?
Yeah.
So my question is going to be, and it's not a slam on insurance, it would be any of these massage or whatever, meditation, whatever, if it works, I don't care. You know, we do too many procedures that are not effective. You know, and I've seen that. So I'm very much aware of, you know, having, you know, treatments that are effective and, you know, proven to be so, to be covered. That's all I would care about. And that's where I would want to know that the insurance covered that. Go ahead.
Right, well, and I know.
Go
you
ahead,
can-
and then I'll say what I need
So,
to say. Go ahead.
and I'm thinking, like, one of the problems we have is pain services are very interested in doing procedures because they're very well reimbursed,
Right.
but not as interested in helping us sort out the root cause of somebody's pain and what other treatments might help them. And so part of part of what I'm, I guess, getting at is if we expand in one way, does that reduce costs in another way that balances out and it is actually better for the patient?
I think the big issue that's always been problematic for me in all these discussions is that we apply one set of evidence criteria for one group of people, meaning allopathic doctors, and then we apply a totally different standard for non-allopathic doctors. And so, you know, like the bar for like I remember when they did pedicle screws and the bar for degenerative spine, there's virtually no evidence to support it, but they were able to get that with FDA approval very easily without any really significant evidence. And you know what I'm talking about,
Well,
right?
sure. A year later, 2 years later, the level above the fusion mass is
Right.
now symptomatic, right?
Yeah.
So,
I mean, that's the problem that I had was that, well, an acupuncturist, you know, the acupuncture project has 117 different diagnoses with evidence. And why is that not good enough? But to get to what Representative Palmer said, this is my goal, is to save everybody money. You know, when I looked and did the math on how many acupuncture treatments I could do on a patient and for the same price as one epidural injection in an OR, it was something like 60. You know, and I was like, I've never done 60 acupuncture treatments on anybody, you know, and I followed one lady for 30 years, you know, and I think that what everybody's getting at is we want a uniform evidence-based criteria. If there is evidence that something works, and especially, I think we're trying to save you guys money. At the end, you know, and the premiums and the people that are getting it. I mean, to me, that's the end game. And to answer your question about Massachusetts, I don't think we have an answer yet, but I could ask Cindy how that worked out.
How
What I
long
will
is-
say is that their bill started out looking exactly like this bill did. The bill that's in is what happened through the legislative process.
Okay.
So
Could I make a couple of
Sure.
comments? Thank you.
I'm
And
sorry for
it's
being-
Sabrina Dunlap. I represent Anthem Blue Cross Blue Shield. So just a couple of off the cuff thoughts in response to your comments. So I think we generally start from a place of wanting something that's less invasive and lower cost. So conceptually aligned there. And I think when you start talking about things like massage therapy, they might be licensed massage therapists, but what kind of evidence are we talking about? And if you get sort of outside the medical evidence realm, I mean, I love going to have a nice massage, but if it's not for a medical reason, I mean, should that be covered by insurance? I think that's debatable. And then you get into, you can mandate, you know, coverage of a service like massage therapy, but then we get into the issue of networks. We can't force providers to come into our network. And we've run into this with providers like acupuncturists, I think maybe chiropractors, physical therapists. And so there's the issue of having people in your network, because if they're not in our network, then, you know, it's not really, it's an issue because then they're not contracted with us. And so it's not really helpful for our members. So I just wanted to point out sort of those practical issues. And I understand, like, conceptually, I think we're probably aligned, but I think when you start to peel back the layers, it's a little more complicated than just saying, okay, if it works, we should cover it.
So do you mind if I ask you a question? You know, I would argue that invasive does not necessarily mean it is, you want to go to the least invasive first. So if you have a fractured femur, you know, doing massage therapy is not going to work, period.
Right.
We know that. Unless you're a baby and, you know, stuff like that, we don't fix them. But, you know, so less invasive, you know, may be the best way to go and the most cost effective down the road because you've dealt with the problem and you're done with it. But having said that, you know, what I'm saying is that, you know, I would push back a little bit on the premise that if it's less invasive, we want to start there first. I would argue against that. And that's not from a surgical point of view. That's just from what is the best way to treat that patient at that point in time, and who's the best person to do it. So to me, really, it comes down to it's, you know, what is the diagnosis? What is the proven effective therapies? Who is licensed to provide that therapy? And as far as I'm concerned, it should be a covered product. Now, whether or not they're in your network or not, that's up to the provider to decide. If they choose not to do it and they want to take cash because they're good at what they do, and there's a lot of people that in hospitals in New York City that will take cash. In fact, that's the way they will do their practices, to take cash. And why? Because it's a status symbol. It's a status symbol to say, you know, I will do, you know, this procedure, but I'll only take cash because I don't want to deal with the Anthems, the Cignas, the Blue Cross Blue Shields of the world. So, again, you know, you're coming at from an insurance perspective. I'm coming at it from a patient care perspective, and to me, it's a little bit different.
Well, we are also coming at it from a what's best for our members perspective. And I just, on this issue of licensing, we can't functionally just base bringing providers or they're not even really providers, just people who provide a service into network simply because they're licensed. I mean, that would be a massive array of professions that are licensed. So we really, I mean, we're health insurance, so it has to be medical. And I think the jury's still out on massage therapy. I mean, I think I'm not aware of like medical evidence that it sort of treats or helps certain illnesses or what, or, you know, diagnoses. And maybe that is out there, but I think we cannot just have it hinge on licensing alone.
Can I ask that a question to that? So if we apply both of those things, evidence-based plus license, does that make a difference?
I think so. Yeah. I mean, we have to have the medical evidence, and it's been a while since I've talked to Dr. LaFleur,
Yeah.
our chief medical director. And again, a lot of this is like I'm digging deep because it's been a few months since we've talked about these issues.
Yeah.
But yeah, I mean, I think those things go hand in hand. Sorry, Heidi.
Yeah, and like I said, I think that those are two key aspects, but I don't know that it's the exhaustive list. So yeah.
Yeah, so my primary goal is that patients have access to the right care at the right time by the right person, period. So to me, you apply the KISS principle to the bill, the legislature that is put forward. You make it as simple as possible. And if what we're talking about is having, you know, for mental health issues, for true pain, for whatever the issue is, you have the right therapy that is proven to be effective, given by the person that is the best to give that, then from my line of thinking, that is the end goal of the bill, from what I can see, from what I look at. And if somebody wants to pay cash, knock yourself out. But, you know, they may not be included, you know, within your network because the modality is not considered a proven effective treatment. But they want to do it anyway, so they pay cash. Let them pay cash.
Good job. I think that's perfect. That's
Well,
exactly what I thought.
What you were getting at before was the idea that if you say couldn't find chiropractors to join your network or because they're too happy just taking the cash, would the insurance company be penalized? And so there has to be some workaround for that.
I totally agree. I'll be honest, when I went through this bill last night and I rewrote it and I re-edited it and things like that, that was one thing that jumped out at me was that whole issue of you have to have this many providers for each of these services. I didn't like that, and that needs
No.
to be changed, but that's what was in the bill. I had a question that I don't really understand that maybe all of you can help me with. So you talked about the whole mandate issue and things like that. What I struggle to understand is when we started with this bill, we just started with a concept. And when it ended up actually in writing, all of a sudden there was a separate sections for group and individual insurance. But we never talk about like the ERISA type groups, the self-insured groups, things like that. I know we can't talk about the federal insured. I don't know why we can't talk about MCOs. Maybe you can clarify for that, but why are they not included in that discussion? Because we're basically throwing out probably about 30 to 40% of the market for reasons I don't understand.
So simply the way the regulatory structure works, at the state level, what the New Hampshire Insurance Department has the authority to regulate is the fully insured plans, both in the individual market and in the employer market, the group market. So the self-funded plans, for example, are regulated at the federal level. Medicaid is a completely separate set of statutes,
Right.
obviously having federal and state partnership there. Medicare, federal. So, one of the other things that we had talked about is the work that's going on in the House Bill 66
Right.
committee or study committee or working group. And, I think from our perspective, and there's a discussion there around doing some pilot work, perhaps either with the Medicaid program or perhaps the state employee program or,
Yeah.
and so I think there is a lot of overlap with what's in here as well. So, that's just the lay of the land that we have in terms of what we can actually impact with our state laws.
So we like I don't know what percentage of the market, for example, in MCO, like the Medicaid expansion has. Can we have any say on that too?
Not through these statutes, you'd have to do it through the Medicaid
Right.
statutes
You could've-
in
Right.
the New Hampshire. So there's, yeah, and
And for
I'm
the-
not a Medicaid,
For the life of me, I didn't
that's
know
not
why-
my area of expertise. So
Yeah.
that's something you'd have to talk with somebody from HHS about in terms of,
Yeah.
what coverage they could do and then what sort of permission, if any, is required at the federal level and that sort of thing. So.
And for the life of me, I didn't really understand why we don't talk about them.
What
I mean,
was your
it's the
initial
same
concept?
issues.
What was your initial concept? You mentioned initial concept.
So, we basically took the original bill that Cindy had created for Massachusetts. That's where all this started. Where we started was to actually look at Representative Lundgren's, it was his bill at that time. No, it wasn't. It was Manjaputi's bill at that time. And we looked at that and then we modified it and came up with what's the second sections of this bill.
What was the primary goal concept that you talked about?
Pretty much everything you just said. We wanted to provide access to these services, and what we were representing was actually not providers, but we were representing patients.
Right.
So it started with the U.S. Pain Foundation, Massachusetts Pain Initiative, the New Hampshire Pain Collaborative, which I was one of the founders of. So the bill actually came from those groups of people with input from the medical society. So physicians got involved. And then once that was done, then we kind of reached out to other groups, and that's how chiropractors got involved, acupuncturists got involved. We've never really had involvement with massage people, psych very peripherally, but the bill is being written from a patient's perspective, and that's kind of why I feel that this is an important discussion to continue because we're representing the patients, not the providers. Does that help?
It does. Did you ever read the book, The Citadel? Did you ever read the book called The Citadel by Cronin, written in 1939? There's one line in there at the very end that talks about the fact that as soon as money got involved in healthcare, it destroyed the system.
That was
Go
1939.
figure, yeah.
Well, this happened in 1939. So, it was prescient, for many reasons. But we faced that with RVUs, in the 1990s. And you knew that when that happened, this was going to be the downfall of medicine in general. But having said that, the concept here, what we're fighting over, whether it's insurance language or we're going to be looking at it. If I have any part of this, it will be from the patient perspective, and not the dollars and cents perspective. So what I'm saying is that the Citadel was present back in 39. And what I'm saying is that my primary goal, as I think is with Chairman Nagel, is the patient perspective, and how this care is delivered.
just so I can say, having read the Sermon on the Mount this week,
Yep.
that statement actually came from the Sermon on the Mount. You can either worship God or money. You don't have a choice. Love or money, basically. So it's been around and he was quoting other people. So that's a 3,000-year-old concept.
And I just
Read the book.
I just want to say we agree and want
Yeah.
we want what is best for our members always. We want them to be healthy. We want them to have access to whatever healthcare is appropriate. We also balance that with, there's a reason we have networks. There's a reason we have a credentialing process. And so part of it is making sure that the people providing the care are providing quality, appropriate care and have all the correct licensing and educational background, et cetera. So I think we come from the same place of wanting what's best for patients. In our case, it's our members. So
I never asked this question before the insurance companies, but it made me think of it when you said that. You mentioned credentialing. Do you do privileging as well? And the difference is that with credentialing for a hospital, say, is that you check the boxes off, you went to a med school, you did this, you did the residency, et cetera. The privileging is what allows you to do in various hospitals, the various procedures that you do. So I'm an orthopedist and I was trained to do spine, but I should not be privileged to do spine. Okay. So my question to the insurance carriers, do you privilege, providers in your network, or are you just credentialing?
I would have to double check. I'm fairly certain the privileging is on the provider, like hospital
It
side.
is in
Yeah.
general,
I don't
but
think.
insurance companies don't look at that and say, this provider should not be doing this sort of management for pain.
I think we try to track certain coding issues and sometimes can find people are doing maybe practicing outside the scope of what they should be, that
Mhm.
sort of stuff. That gets into a realm that is outside my general wheelhouse, but yeah, I think generally privileging is outside our realm.
Okay, thank you.
Go ahead.
I want to go back
Trying to keep
to,
minutes here. This is
Yeah.
challenging. Go ahead.
it's very important to me that mental illness get to be part of this. And that's for different reasons than what we've heard. Everybody knows that stigma is a major issue. In other words, in the legislature, there are going to be people who don't want to hear about mental illness because their perception is the public perception that it's stigmatized. And if you support mental illnesses, there's probably something the matter with you. And also, there is insurance coverage for mental illness. That's a very broad spectrum, from neurosis to psychosis. And some are highly treatable and some are extremely difficult to treat. And if you talk to the average person, they don't think of it as an illness. They think of it as a problem. So that from my point of view, anything that I can associate mental illness with that clearly defines it as an illness and treatable. And frankly, I go back to the days when the old New Hampshire hospital was there. And there are still people who believe in that old hospital. You never left there. I've had friends that were spent their whole life at New Hampshire Hospital because nobody knew what to do. I was never critical of that, but until Thorazine came, there was really no treatment. And so I think what I'm talking about is a different type of problem in terms of inclusion in the pain concept. But in a strange way, mental illness causes pain for other people as much as it causes pain in individuals, and therefore a very different problem in terms of insurance coverage and who is available. So I keep pushing this, and I have for years. And I think this is an unusual opportunity for people to begin to look at mental illness in a different way. And that example of how somebody was carrying pain for years untreated because her behavior probably was provocative and making her, it's a different kind of reaction to pain. That reaction is to be provocative and irritate people instead of the average pain. I've had some recent pain, and frankly, I don't get much sympathy from the doctor that sits next to me. He's been very, I have to be honest, he was very helpful to me at a difficult time. He saw that I got a ride home every single
So
He's a
Representative,
lot nicer than.
Representative McKay, Representative McKay, I can say that, you know, the carriers do provide certainly a wide and deep array of, you know, mental health, behavioral health services. So, and I think that
Probably
that was
ask.
reflected a little bit in the definition of pain that came up in the House Bill 66.
Mm.
And I apologize, I have to run to an 11 o'clock meeting, so
Oh, I'm sorry.
that's okay. I just
May I-
wanted you to know why I was running off.
May I
I'm
just
really
say-
glad you came. Thanks.
May I just ask that in this chart that you provided, if you update it, could you include mental health services just so we know? I mean, I'm just, they're probably covered, but,
Yeah, that would be a
well, no,
whole,
okay.
Yeah.
But in general.
Were you
they are-
asking about, I mean, mental health services, there's a vast array that are
Right,
covered.
I guess maybe looking at if there are ones that are included in this current bill that are not currently covered. Just
I
so we
see.
know.
Okay.
I mean, maybe that's a lot to ask, but are we asking for more in this bill than you already
Gotcha.
covered?
We
Okay.
think that CBT is like really important
Yeah.
for managing chronic pain, so that's a big issue, so. Representative Dolan? I feel guilty. We should all just be at a small table.
I know. We could rearrange the room. We'd probably get in
Well-
trouble though, right?
I did do that once.
Yeah, they can
for the
come and sit
video.
down. Yeah.
Oh, yeah, you're right. Good thinking.
Thank you, Mr. Chairman. Just 3 quick points. My name is Representative Tom Dolan. I'm actually on the ED&A committee, so some of the questions you had, probably you might want to think about bringing in OLPC to talk about some of the licensing and so forth. But I had 3 quick points I wanted to make. I'm a co-sponsor. I'm here representing primarily the sponsor, Representative Lundgren. He's a practicing chiropractor, and in his clinical experience, he sees a lot of people that come to him that are using opioids
Mhm.
for their pain management. And they come to him with the question is, can you help me get off of these opioids? I don't want to take them anymore, but I'm afraid to stop, or the pain is such that I can't stop. So that's one of the issues that I know Representative Nagel talked about. The fact that you've got this for this summer. I would encourage you not to let this go, to continue to work it. There's such a treasure of opportunity here to help New Hampshire society. But that's one the chiropractors are seeing in their practices of how to transition those who are on pain to something that is maybe has a massage solution, or maybe it doesn't. But the representative mentioned it really depends on the particular case. The second issue was referred to me by a classmate of mine who is a practicing anesthesiologist, and he's now transitioned into pain management. And what he tells me is that those folks, after they have a surgery, for example, they often transition to an opioid solution or opioid-like solution. And then the next step is to transition off that medicine. And that's the difficult part, is to how to get off the medicine and what do you use, what assistance is available to them, maybe mental health assistance, maybe medicinal assistance to get off of that medicine and transition to a less medicated world for them. And thirdly, I wanted to mention an experience that I've had. I'm a six-term town councilor in Londonderry, and a lot of experience with our first responders, especially in the fire department, dealing with the opioid crisis that we've all been dealing with for the last 20, 25 years. It is such a crippling force in our society that it's, again, something not to let go of. That if we've got this tiger by the tail, let's keep wrestling it to see if we can come up with some good solutions. There's one issue that's beyond the scope of what you're talking about today, but I'm happy to come back at another time. I brought this to HHS a couple of years ago, and that is what I'll call medicine cabinet diving. And that is those of us, mostly parents, who have experienced some pain and some pain management and have not finished out their prescription. All the doctors say, finish your prescription and be done with it. But they end up leaving half a dozen pills in the medicine cabinet, and then at a house party or whatever, somebody discovers that and decides to take advantage of that situation. And there is I propose a solution to that, believe it or not. It was not well received by the Chief of Police Association.
Oh, I know where you're going.
So, but again, I'd be happy to talk to you about that some other time, but
Yeah, we should. I really appreciate what you just said, because this has been a 35-year process for me trying to find that sweet spot. Because opioids are important. We use them at end of life. We use them for acute care. We use them in selected patients with chronic pain. And they have value for the right person. And we've been saying that for 35 years. And we've actually created our first set of opioid prescribing. I'm being whatever. We created our first set of opioid prescribing rules. We wrote them in 1998 for the state. And I still to this day believe that if we had taken those seriously, that we could have prevented a lot of the problems that did happen. Because I'll tell you, the media took off. I have a beautiful headline from U.S. World News and Business Report about how morphine's the cure for everything. I mean, that was in the media, and I love how we like to blame Big Pharma for everything, but you know, there's a lot of people to blame, but we really tried hard to hit the sweet spot. And I think that is, to me, why I really appreciate what you just said, because that's why what we're doing here to me is important.
So
and I
I
appreciate
would-
what David said about what you said for him. That was wonderful.
I would encourage you to not to let this go, to keep studying it and find some solutions, because we so badly need it in our society. So I'm here if you have any questions, but I'm not an expert and I'm not a practitioner or a clinician.
I'm trying to think, do I have questions for you? Because Dr. Representative Lundgren and I have talked a lot about this for several years, and I really sad that he's not here, but I think when we meet next time, he can be.
He's
So,
on vacation, so I'm
yeah,
sorry about that.
figures. He's got the best tan in the state house for a reason.
I'm wondering a little bit about the silos of medical care, where if it costs more for the insurance company to provide
Yeah.
expanded services, but there's savings somewhere else, the insurance company doesn't see it, the rates go up. And so to what degree that's going to be a confounding thing? Because, if towns or ERs end up with a lot of people landing there, now presumably if they have, with overdoses, say, presumably if they have insurance, that's going to get covered, but it's going to be covered by insurance. So if we can prevent that, that should save the insurance company's money. But on the other hand, there are a lot of expenses that go with opiate overuse that are not covered by anything other than, people trying to piece together things. Like Sullivan County has a whole medical assisted treatment plan that's covered not through insurance because these people don't have it.
Yeah.
And if we could lower that cost, because we just, have a big increase in the county tax rate,
Sure.
and some of it's that kind of expense that maybe would be reduced and how do you sort of,
Those of us on the front lines, the moms and dads in the homes on the front lines, what they run into is scary. And it's usually in the laundry room as they're emptying the pockets before they put the jeans in the washing machine. What's this? What are these pills I just found? And what do I do with them? Where do I bring them? Do I flush them down the toilet? No, that's not good for the environment. Do I throw them out the car window next time I go to the store? No. So what do I do with them? So that's I'll leave
Right.
you with that little tidbit of
on the plus side, when I had shoulder surgery 2 years ago, I got sent home with an ice, an ice pack thing and 4 oxycodones, and I took 2 the first night at the surgeon said you better take these the first night, and then
Okay.
after that I never needed anything. Now that's partly luck that I didn't end up having a lot of pain, but also partly what's changed. When I had neck surgery 10 years ago, I got sent home with 60 oxycodones.
right.
So I think there's a lot of the practice that's going the right direction, but we still have.
The education that's in here is very important. I like you, I had some surgery. I had a hernia surgery, and I was being discharged. The nurse brought me prescription for 30 oxycodones, and I said, I don't want them. I said, give me 5,
Right.
and we'll keep the other 25 in the pharmacy. I don't want that many, because then I got to dispose of them.
Yeah.
And I didn't want to.
I'm gonna give a plug here for Dartmouth,
Right.
because
that's all right.
Dr. Barth and others, we don't agree much on chronic pain, but on acute pain we do. But they published a study on prescribing opioids after routine surgeries and came to the conclusion that everybody's throwing pills out
Well,
and that they need to prescribe differently.
yeah, because for
And that's why they
those
changed the
that
state law.
are here that have
Yeah.
some gray hair, remember the fifth
Vital sign.
vital sign
Yeah.
that we used to have to live by in the 90s, and that was
Yeah.
pain. And so we were forced, in large part, not by pharma, not by anybody else, except by our own societies, to give away, opioids at a very excessive rate. So we did have the fifth vital sign. It's taken us a while to get over that hangover.
I remember the number of patients who would say, I have a right to,
Oh,
Right.
yeah.
yeah.
If you look at my description, you have a right, but you also have responsibility. Because I actually just wanted to tie in everything that all you guys are saying, because I think it's really important legislatively. And it's why I wanted to differentiate between what we're talking about in our integrative care committee and what we're talking about here. What you were saying, Bill, if I can call you Bill, is when we created that integrative care committee, we acknowledge that in chronic pain that multimodality therapy is important, that it be coordinated and integrative, and it needs to be done in a cost-effective manner that nobody's figured out how to do yet. And so that's the whole point of that committee, is to figure out strategies to do that using existing community services, and and that's been exciting, and there's a lot of people that are really interested in that. The difference between that and this bill is we're looking at unimodality therapies for really more, some of this is for chronic pain, but a lot of it's for acute pain. You're not going to go to 50 different providers, hopefully, for a sprained ankle, but, you might find that you want access to a chiropractor for an acute back pain or whatever. And there's clear evidence to support that. And so and I think it's really important that we differentiate that these are 2 different bills, even though there's a lot of overlap. And that we do need to give access to integrative care here, but also unimodality or bimodality care easily, cost effectively, and do the right thing. And I really, you said it 3 times, I think, that how important what we're doing here is. And I really appreciate that, because this is a really big deal to me.
Thank you for what you're doing. It's
Could I
very
ask you a
important.
question?
Sure.
In reality, I remember when we looked at this bill, 554 back in 23, and I wrote down some comments I made here. One of them was, I agree with the intent, but it should not be legislated. And there's a lot of us that are in practice that know of the alternatives for non-opioid management of pain. But do we use them regularly? No, we don't. Should we? Perhaps. But the question I have, and again, as a co-sponsor of the bill is, I wrote down should not be legislated. What should be legislated? I guess that's what we're trying to get
Yeah,
at also, is
exactly.
what should be legislated and what should not be legislated. And I think those are, you don't have to answer that now, but if you can send to our chairman, you know, because I think we're gonna have to work on this a little bit longer.
Sure, I would relish that opportunity.
Yeah.
But it's a great question. Probably a group of experts like yourselves
I'm not an expert.
that, I mean, that are clinician, that have clinical experience, probably have a much better group of suggestions than I would have. But again, talking with Representative Lundgren, he's just looking for alternatives to opioids. And what are the alternatives, and what can we do to provide those alternatives to our patients?
So my question to us, as well as you and to Representative Lundgren, is what should we do legislatively? Because I'm always hesitant, quite honestly, to legislate medicine and the care that we provide, because I think that we do it well majority of the time. But having said that, we were given that fifth vital sign 20-something years ago, and we're still getting over that hangover. But I couldn't agree more. You know, my goal is patient-centric. It's access to whatever modality works best. It is to basically know that it's effective, that the provider is good at giving that modality, and then to have them not suffer financially from doing that. So how we do that legislatively, I don't really know the answer to that, but that's why I would reach out to you and to Representative Lundgren and others to say, you know, what can we do to streamline this process?
And I think I can speak for the chiropractors because I met with both the chiropractic associations, their leadership, to talk about this. And I think there's two driving forces for this particular bill. One is the chiropractors, more so than any other alternative provider, and then the other is the patients. You know, as we were talking about before. But when I first arrived in New Hampshire, you know, people would go to see a chiropractor and go see him 2 to 3 times a week forever, and insurance is paid for that. And now they're struggling to get any coverage, you know, in a lot of situations. And so, you know, they went from famine or feast to famine. And so they want to bring it back to some seat at the table. And they're really the ones that are the driving forces. I'll be honest, I haven't had a lot of, you know, acupuncturists, you know, they're very interested in this, but they're not the driving force. But I think from a legislative standpoint is they feel like they've been left out. And they feel that this is the way they need to do things to get back left in. And whether we need to do that or not, that's another story. But that's their feel. I know that's their feeling. That's what they vocalized to me. And as a doctor who treats pain, I valued what they offer for a very long time. So
It's in terms of management, 'cause whoever becomes speaker technically decides what committee that's going to. It should automatically go to health, but you never know. But there's a FN after the HB on top. That means a fiscal note. So I looked up the fiscal note and they don't have one.
Yeah.
But that doesn't mean there won't be one. And therefore, that means it will go to finance committee. So that we want to keep in mind that what committee gets this bill is very significant. And what we sometimes think is simple, you know, that it just should automatically go to health. Doesn't necessarily happen.
if I could say, this is a bill that exists and it's in our committee.
Okay.
Yep.
It should
And-
stay there.
Yes, and
Yeah.
that's why we're dealing with it.
So do you know what the issue is with the fiscal note?
No.
Yes, when we first put this up, fiscal impact, due to time constraints, LBO, the Office of Legislative Budget Assistance,
Yeah.
could not provide a fiscal note. But they didn't say that there should be one or should not be. They just said because of time constraints, and this is back with the original bill.
Right, and
Yeah.
so my question about that is isn't the fiscal note what it's gonna cost the state? Not that the state
Yes.
shouldn't care whether patients or insurance companies pay more, but shouldn't it, I mean, if it's not gonna cost the Health and Human Services or whatever other part of the state more, then it shouldn't have a
This is what
fiscal note, right?
confuses me, because in one of my other bills, there was a fiscal note. There was like 0 cost to the state.
Yeah,
And then they put an F fiscal note on, and then they were trying to estimate the cost to other entities that weren't.
right. And I mean, I don't
I
wanna have
don't
it
understand that.
cost a lot more either, because same county budget, the health insurance cost is up 16%. So we don't want to keep
Yeah.
pushing costs there too, and that's why I'm really interested in whether, aside from better patient care, if we can that doing this right might lead to actual lower costs.
Just so you know, I've done 64,000 epidurals in my career. If I never do another one, I'm fine. And would I ever let anybody do it to me? Probably not. So, I mean, and that's an expensive intervention. And I just think that's what we're trying to do, is save the system money by providing access to stuff that doesn't cost as much. And the other thing that's really important for pain management is self-management.
Mhm.
And when you time somebody into me to do an injection, they can't do that on their own at home, I don't think. So, you know, we want to give them as many tools as they can use that are cost effective, so they don't need to run to the doctor every time they have a problem. They can manage it themselves, and that saves everybody money.
I think we should check, I'll be glad to go to the LBA and see if they do have a fiscal note.
Sure.
Because that, if it costs outside people,
Well, right,
those become opponents of the legislation.
Right, yeah.
right. I
So
can
you
see
need
a
to
certain
know that.
representative on the finance committee not liking this.
They might actually certain people might actually like it after I saw it the last session.
Yeah.
Can I just move this to the next step? So, we should probably start talking about our summer study. I'm just thinking who should be invited, to a discussion, and like the 4 of us are here. We don't need more than 4. I mean, it's,
Where is Marchand? Is he on
he,
vacation?
no, he,
He's on.
he had a
excellent.
conflict.
He's a great member.
And he wanted to be here, but he couldn't. And Chairman McDonald wanted to be here also. This was a really big thing for him. But he's out of town, so so there's 6 of us. And then, I mean, who else should be there? And
Well-
and I can name people off the top of my head, but you guys go ahead.
Would it seem to me like the stakeholders should be there?
Yeah.
So the chiropractors, somebody that represents chiropractic, somebody that represents the insurance company, somebody that represents the acupuncturist, you know, what is their, opinion regarding this bill?
So I already have names for all those
Yeah,
spots.
right.
So and we should let the insurers come back.
When
And
would we want to meet again?
what's that?
When would we want to meet again?
You know, it's kind of funny because we've actually achieved something here, I think. So you don't want to put it off too long.
Right, well, and the other, right, I was gonna say the other thing is that I will completely have forgotten what we talked about today if it goes too long.
I have like 47 pages of
Okay,
minutes
so I'll
here.
be reminded.
I was thinking like mid-July. Is that too far away?
I'm gone until the 12th or 13th, so
All right, after that.
after the 13th.
So,
I'm sorry, you're hurting my. So we're talking about pain. For me to look at you hurts my neck. So that's why I haven't been looking at you that much. I'll grab my book. And this is the other thing. Do we want it to be Zoom or do we want it to be in person? Because if it's an ad hoc meeting, we can do what we want.
I think it's much
Thanks.
better in person.
but it would be,
Have people have the option.
Thanks
but-
for coming.
yeah, thanks.
That was
Thank you.
really helpful.
I'd say in person, but if people get stuck and they have to do
Yeah.
Zoom, they can do Zoom, but it's much,
So-
having attended meetings by Zoom, it's so much better in
Yeah.
person.
You don't feel, yeah, and we actually have a hybrid thing that we're doing for our thing tomorrow we're doing it at the New Hampshire Hospital Association. I don't know if we can use state property can we use state property for a meeting, for an ad hoc meeting? I mean, I
Sure.
could check.
Oh, sure.
Yeah.
So if we can, like, if we can meet here on an ad hoc
It's
basis,
just to get it in the calendar.
all right. But if it's ad hoc, we don't need it in the calendar.
As long as they fix the air conditioning.
That is all gonna be up to when, our daughter has the baby, in which case I might be in New York, so then a Zoom would be handy.
Okay.
Yeah, it's an option.
Do you want to do like Wednesday, July 7th? That doesn't work for you, 17th?
Let me open my, yeah, that, I think I'm
You make
working,
it.
Yeah.
yeah, this, I'm working
You're
that,
going to get so sick of me this summer.
I'm working that day unless you wanna have it at like 6 AM, in which case.
No, no, I'm sorry. I'm a physiatrist. We don't start that early.
So I'm either free the week before, pretty
But
much,
you're not.
or the
How
week.
about the week after, the 24th?
Sure.
If we have 2 meetings, that should be good enough.
I would think so.
Yeah, and then we'll meet as a committee in September.
Right.
This is fun.
There you go.
Legislation in action. Oh boy. Yeah. Does that work?
You know what time?
Same
10.
time. 10 works good for me. We made a decision today. Actually made a lot of decisions. So what I'll do is
Decision about when to meet. at
right.
least,
Well, we kind of decided like what not to do today.
What the goals are too. I mean,
Yeah,
I've
that
got to
was
turn it into
important.
some goals.
Yeah,
So
it's-
I'll put together all the minutes.
Okay.
And I'll try to do as good as I can. And then I'll share them with you guys if that's all right with you. I don't know what the requirements are for posting them. I don't. Yeah, yeah, and then
She's just the committee assistant. Well,
right. Good. I figured keep forgetting about her.
she takes care of all those.
She's
stuff.
really wonderful. So I'll just give her my notes and tell her to type it up. No, that's never happening. Well, this was fun. All right, so we'll do it then. And then, I mean, can I just ask like one brief snapshot question? Like, what, and you don't have to answer it if you don't want, but just how I amended the bill. And if you don't want to answer, don't worry about it. Yeah, if you haven't looked at it, don't worry about it.
Yeah, I was gonna say, I read through it, but it's gonna be a lot more productive to go
Yeah, I
back and
get
look
it.
at it again now that I
I
have that
feel
more
really
history.
guilty about what I did, but when we saw the original bill, the pre-554 version, it had a huge number of problems only in that everything that was already in it, except that they were going to make you write up every time you you had to write up a plan that you had to submit to somebody, you know, about what you were doing that didn't involve opioids. We already have to do that. It's in the statute, it's in the medical rules. So there was nothing in there that we didn't have to do already. And they put in a lot of modalities that we know we're not going to be able to cover. So we had to get rid of a lot of that. Then we struggled when we discussed the license thing, which was not in the original bill, the first section. That was really important to us, that it be a licensed provider. That evidence-based, that was not in the original bill. That was important. Yeah, right. Oh, good thinking.
So, yeah, because the other thing would be, like, if it can't increase administrative burden, because otherwise, I mean, you don't want somebody to go like, well, I could jump through these hoops, or I could write for some OxyContin.
Yeah,
Although
it
there are hoops for that too, but
yeah. Well, it was crazy. I just took one look at it and I just saw nobody's going to want to do pain management if you do this, and that
Right,
was the barrier.
because people already don't want to do
Right,
pain management.
right. And this
We
is,
want to make it easier.
and I understand what he was trying to do and what they were trying to do, but it didn't make, it wasn't going to work, and that's why we sat down as a group to try to figure out, well, how can this has value? How do we make it workable for a doctor to do?
Yep.
Is there anything in that bill that costs money
To
to the state?
I personally, you know, the cost of the paper of printing it, I don't,
No,
I think it's to the system really.
Yeah.
But
Because,
with the original bill, yeah, because, and that may be why the fiscal note's a challenge, is because in the original bill, there was a form a doctor would have to fill out that would have to be submitted to somebody, and that somebody would have to keep track of that. So that was maybe where the fiscal vote came from.
But if the goal is access, the goal is. You have licensure, I mean, that's already stuff. But if we can keep the bill really simple, straightforward.
So you can't retire now. No.
Well, I think it's probably, you have to write him in.
All right.
I think.
Okay, we'll just have this mass Lebanon campaign, or
Well,
you're in Hanover, right?
Something anyway,
Right. And then you can invite him to testify.
whatever it is.
I was so happy when you said you were coming, because I thought, when I knew you weren't running, I thought you'd be like a lame duck and you wouldn't, because I was psyched when you said you'd come.
Actually.
I was psyched when you said you'd come too.
Yeah,
Phil was a given.
I decided at the last second.
Say hi to Nick LaFleur.
What's that?
Say hi to Nick LaFleur. I'm on the American College Admissions Council with him, so.
He is wonderful, and unfortunately, he's retiring.
Is he retiring from you too? Oh, because I knew he retired from practice.
He is awesome.
He is.
Thank you.
Bye-bye, thanks. Done with it.
Yeah, I'm done.
Well, that's it. That's,
Oh,
maybe that's why we should.
can we make a motion to adjourn?
There you go. I'll take it.
All in favor? Aye. Boom. Here.
Good.
There. That was fun.
That's not.
That's not. I know. I was gonna bring. I have a Stanley hammer in my truck. I was gonna bring it in and do that, but I didn't want to dent the table.
When you get to be a real chairman, they'll give you a gavel.
Oh, really?
Remember last time you sat with a big chair?
Oh, yeah. I remember you took a picture.
I did.
I don't even remember what that was of or what that was about.
What it was up, but we've been sitting with a big chair.
I remember you making me. I got a kick out of it.